Robin Sadel. I'm the clinical resource nurse for the cardiovascular service line at Nebraska Methodist Hospital. It's my privilege to introduce Doctors Emily Patel and Michael Peters. Dr. Patel is a partner at Perinatal Associates, and Dr. Peters is a cardiologist at Heart Consultants Methodist Physician Clinic. They will be sharing cardiac complications during pregnancy and postpartum cardiomyopathy. So welcome.
Hi, I'm Emily Patel. I'm going to talk about maybe the only thing that might scare a cardiothoracic surgeon, which is pregnant patients. And they may not even be scared by that. But we're going to talk about pregnancy and cardiac complications. This is a huge, huge topic. We could spend multiple days talking about cardiac disease and pregnancy. So I'm really just going to be scratching the surface here. And I really want to hit on some really important points about workup, treatments, things like that. So I included this picture of the Grand Canyon just to demonstrate again, this is a huge, huge topic. So we'll do the best we can with the time we have. Objectives today are review the background of cardiovascular disease and pregnancy, some risk factors, discuss physiology, and then I'm going to talk about some specific conditions that contribute to high morbidity and mortality. So they are rare conditions, but they contribute very highly to mortality and pregnancy. And then just discussing some warning signs and treatment options. So to start, 1 to 4% of all pregnancies are affected by cardiovascular disease. However, it is the leading cause of death in pregnancy in the United States. It accounts for about 27% of maternal mortality. 25 to 50% is preventable. So again, really important that we're all recognizing what some of those warning signs are so we can prevent these things from happening. This is often divided into congenital versus acquired heart disease. Importantly, with folks that have congenital heart disease, we're seeing more and more of that, but fortunately they do pretty well in pregnancy. They're getting corrected early on in their life and they have really close and rigorous follow-up. And those moms tend to do quite well. It's the folks that have acquired heart disease that we're seeing the higher rates of maternal morbidity and mortality. So with those acquired ones, morbidity and mortality is on the rise. That is really due to a couple factors. One is increasing maternal age over the last 20 years. In the 70s, the average age was about 20 to 21. Now, the average age of childbirth is closer to 28 years old. So we're seeing that rise in age, in addition to higher rates of obesity, diabetes, and hypertension. So risk factors related to mortality specifically. So race is huge. Non-Hispanic Black women have 3.4 times higher risk of death from cardiovascular disease. And the CDC actually just came out this morning with an update of the maternal mortality. And unfortunately, non-Hispanic Black women have had an increase in mortality compared to their white counterparts. So it's about 50 per 100,000 compared to white women, which is about 14 per 100,000. So this is an issue. Age as well, age greater than 40 is associated with a 30 times higher risk of death as compared to women under the age of 20. Hypertension, 13-fold increase of myocardial infarction and about an 8-fold increase in congestive heart failure. Obesity, especially in combination with obstructive sleep apnea. So this is something we screen for at intake with our new pregnant patients. We're asking them about snoring at night, and then certain thresholds for BMI typically are going to warrant or prompt us to do an evaluation for sleep apnea and get a sleep study. And then social determinants of health, just really important for us to be thinking about bias, barriers to care. Do they have transportation? Do they have insurance? Are they able to pick up their medications? And then just mistrust in the healthcare system and things like that, making sure that we're bridging those gaps. So I want to talk about 2 pregnancy risk predicting tools that we use. So CARB-PREG is one of them, and this was based on a study to determine what risk is for cardiac events in pregnancy. And then the WHO also has a tool that we commonly use in conjunction. So these ones are the ones that we're going to use when we're talking about risk factors in pregnancy. So this is a busy slide, but what I want to point out here, so this table 1 here is based on that study, this CARPREG study. And for each of these predictors, a patient would get a score. So for example, if they have coronary artery disease, they're going to get a score of 2 for that. If they have also a mechanical valve, they get a score for 3 of that. So we add that together, they have a score of 5. So then we go over here to the CARPREG score chart here, and it would indicate that if we're over 4 for your score, primary cardiac event risk in pregnancy is over 40%. And those cardiac events include cardiac death, cardiac arrest, an arrhythmia, right or left heart failure, stroke, a TIA, thromboembolism, an MI, or aortic dissection. So all very, very serious events. Okay, so this score will help us counsel patients either before they get pregnant or early on in pregnancy to give them an idea of what their risk would be moving forward with the pregnancy. WHO, again, this is going to be surface level, but it will be here for you for resources to look at. But this is classified class 1 through 4. Class 1 would be no increased risk of mortality, but a slight increased risk of morbidity. And we usually do some sort of cardiac evaluation once to twice in the pregnancy. An example of that would be mitral valve prolapse. So getting an echocardiogram at baseline, and if everything is going well during their pregnancy, they have no change in symptoms, then no need to repeat that. So that would be a class 1. Class 2 would be a small increased risk of mortality and a moderate increase in morbidity. Usually in these folks, we're doing an evaluation about every trimester. An example of that would be a repaired tetralogy of Fallot. And then we have kind of this gray zone, class 2 to 3, based on their individual diagnoses. But an example of this would be somebody with a bicuspid aortic valve that has an aorta measuring less than 45 millimeters. So just some examples there of who would fit into those categories. A class 3 is a significant increase of maternal mortality or severe morbidity, and we really need expert counseling here in conjunction with our cardiology colleagues. Intensive monitoring throughout the pregnancy and evaluation about every month roughly. So another example of this one would be somebody with connective tissue disease like Marfan syndrome with some aortic dilation present. We're going to want to monitor that aorta very frequently throughout the pregnancy and make sure it's not expanding. And then a class 4, this is a really extremely high risk of mortality or severe morbidity. If I'm seeing this person pre-pregnancy for counseling, we're advising against pregnancy in these situations. If they're coming to us early in pregnancy, we would even discuss termination of pregnancy if they are at a really high risk such as this. And then if their pregnancy does continue, we're going to talk to them and care for them as we would somebody in that class 3. So an example of this would be somebody with aortic dilation over 45 millimeters with Marfan syndrome. And so these would be people who would be a very, very high risk. And an example, and just to kind of give you some perspective on that, with Marfan syndrome in particular, with that aortic dilation, they have a risk of aortic rupture of about 20% in pregnancy with that finding, and about 30% risk of mortality from that event. So this is a super high risk for patients that have that diagnosis. Okay, I want to talk about physiology. I think this is super important to help kind of put the pieces together for why these conditions can become so dangerous in pregnancy when people have been doing pretty well outside of pregnancy. So we talk about systolic and diastolic dysfunction. So with systolic, it's a pump problem with forward flow. Diastolic, a filling problem with overflow oftentimes. So focusing on blood. So first off, plasma volume expands by about 50% in pregnancy, and it hits its max around 28 to 30 weeks. This is really critically important to know because we will have patients who have cardiac disease in pregnancy and they're 15 to 20 weeks and they say, gosh, I feel great. My blood pressure is good. I'm not having any symptoms. I think I'm going to do just fine. And the reality is that oftentimes we don't see severe complications or symptoms arise until we really hit that peak closer to the end of the second trimester or third trimester. So that's important to know from a physiologic standpoint. Additionally, red blood cell production increases by about 25%. So because of that discrepancy, we get a bit of a dilutional anemia. So important to know for baseline. And then we get an increase in coagulation factors, and that helps prevent hemorrhage after delivery, but it can have consequences as well. The benefits are reduction in viscosity of the blood, an increased reserve from blood loss at the time of birth, increased cardiac output to the placenta and the maternal organs, and then a reduction in the risk of hemorrhage at the time of birth. But there is that risk, as I mentioned, of thromboembolism because of the coagulation factor increase. A little bit about hemodynamics. So cardiac output is increased in pregnancy. We get an increase in preload, a reduction in afterload, and an increase in heart rate. Cardiac output to the uterus in the first trimester is about 3% to 6% of cardiac output is going to the uterus. By term, it's 12%. So it substantially increases. Heart rate, very normal for us to see kind of a baseline tachycardia. Low 100s is not uncommon. It's a baseline increase from about 10 to 30 beats per minute, very normal. Blood pressure, kind of going back to that 20-week example that I shared, it naters about 18 to 20 weeks with a progressive increase until 40 weeks. So oftentimes, again, we are having people feeling pretty good in pregnancy around that 15 to 20 week time frame for these reasons. Uteroplacental circulation. This is important, especially in the postpartum period, to recognize why we worry about pregnant folks after they've delivered. Immediately after, that's really one of the highest risk times for the heart to be stressed. And so uterine vascular tone is relaxed in pregnancy. The uterine artery increases in length and diameter, and it's doubled by about 20 weeks. And uterine blood flow in the first trimester, it's about 50 to 60 milliliters. By 28 weeks, we're at 185 milliliters per minute. And by full term, we're at 450 to 750 milliliters per minute going directly to the uterus. So that explains why we can have massive hemorrhage at the time of delivery, and why it's so important that we're paying really close attention to blood volume and things like that. After delivery, that blood has to go somewhere. And so it's going to go back to the heart, and in what's called an auto transfusion, basically of about 500 milliliters. So we have a kind of an immediate stress on the heart after delivery for these reasons. And postpartum. So going back to that, I got a little bit ahead of myself, but within 10 minutes, cardiac output and stroke volume increased by 59 and 71% respectively. And then you get that increase in that stroke volume due to the preload from the auto transfusion that I just mentioned. Additionally, you get a reduction in the compression of the inferior vena cava because that uterus is starting to involute and go down in size. The blood pressure will peak about 3 to 6 days postpartum. So this is another important thing for us to be recognizing, is that we might have a little bit of a honeymoon period for the first couple of days where blood pressures are looking good, and then oftentimes can start to spike on those days. So following up really closely is important. Blood volume and clotting factors don't really return to baseline until closer to 8 weeks, but it really takes about 3 to 6 months for physiology to get back to completely normal. So talking a little bit about presentation and workup. So how does cardiovascular disease present in pregnancy? So we can see heart failure. Dr. Peters is going to talk about that in detail, so I'm not even going to touch on that one. Myocardial infarction, arrhythmias, and aortic dissections. These are the really highest risk conditions that we're going to encounter. Evaluation is really going to be the same as somebody who is not pregnant. Troponin, very specific to myocardial injury, but of note for pregnancy, can be elevated in preeclampsia with a pulmonary embolism or chronic renal disease. EKG, we can evaluate for ischemia and arrhythmias, but it's also important to know that in pregnancy, we do see some nonspecific ST and T wave changes at times. Chest X-ray, very simple, easy for us to use. We can evaluate the cardiac silhouette very easily, so we can tell if there's cardiomegaly that needs to be evaluated further. And then we can also see evidence of pulmonary edema, obviously, on a chest X-ray. And I put in parentheses there BMP, so just for a lab value that we can look at for fluid overload, that's one that's often ordered as well. Echocardiogram is going to really be our gold standard if we really think that there's something structurally or functionally wrong with the heart. An echocardiogram is what we want to get in those cases. Anybody who has known or suspected cardiovascular disease in pregnancy, it's really important for us to get that at baseline so we know early on in the pregnancy where they're at. That way, if they do develop new symptoms, we can see if there's been a change from baseline. CT scan, obviously for a PE workup, because a lot of those symptoms have overlap, and we can also evaluate the aorta that way. Of note, we can evaluate the aorta and dilation with an echocardiogram as well. And then a Holter monitor, so somebody who's having frequent heart palpitations, dizziness, syncopal episodes, things like that, a Holter monitor would be very helpful and useful in those cases. So mitral stenosis, this is the most common rheumatic heart valve lesion, and there's a ventricular diastolic filling obstruction in this case. Moderate and severe are really the highest risk for failure in pregnancy, and ideally this would be corrected pre-pregnancy, but this would be one that we want to be monitoring really closely throughout the pregnancy. Complications include arrhythmia, like atrial fibrillation, venous thromboembolism, pulmonary edema, pulmonary hypertension, and right heart failure. Medical treatment would include kind of the basic things like beta blockers, atenolol, metoprolol, both very safe in pregnancy. Diuretics, I have an asterisk there. Traditionally, we try not to use diuretics in pregnancy. We don't want to really alter that fluid status that we talked about, and there's reasons for that increase in volume and things like that. So we are careful with those, but can use it in the right patient when necessary. Anticoagulation, especially obviously if there's AFib or an atrial thrombus present. And then surgery. If symptoms remain, then surgical treatment is necessary. Obviously, we would prefer that to be done prior to pregnancy. And what to avoid? We want to avoid tachycardia. So that's the point of our beta blocker, because tachycardia reduces that filling time. And then hypo and hypervolemia. So everything needs to be just right in pregnancy is the bottom line, but we have to really be careful about changing those fluid volumes too much in one direction or the other. So the hypovolemia can lead to inadequate filling and decreased cardiac output, whereas hypervolemia can lead to pulmonary edema. So a very tight control of fluid volume. And just of note, again, that kind of goes back to the fact that right after delivery, again, we really have no control over that auto transfusion that happens after delivery. So that's why that time frame is so critical for our patients that have these heart lesions, and that we need to be monitoring super closely. A little bit about arrhythmias. So it's very natural to have an increase in arrhythmias due to the blood volume increase that occurs in pregnancy. A lot of pregnant folks will tell me, I just feel like I'm having heart palpitations. I feel like my heart's skipping a beat. If they're otherwise asymptomatic, they're not having this regularly to the point that it's disturbing their day-to-day activities. This would likely be just benign PACs or isolated PVCs that we're probably all having, but just unaware of. But when the blood volume increases so substantially in pregnancy, it's a lot more noticeable to them. So really, we're looking to see if they're having any symptoms, like I mentioned, syncopal episodes, dizziness, lightheadedness, things like that. And sometimes symptoms don't correlate all the time, so important to recognize that as well. With tachyarrhythmias, we're going to be over 100 beats per minute. It can be atrial or ventricular. And then we want to evaluate for structural disease in these cases too, so getting an echocardiogram. And symptoms can be related to the degree of the tachycardia and their ability to maintain their cardiac output. So in these cases, we're going to get pounding heart, shortness of breath, chest pain, dizziness, and syncopal episodes. Aortic dissection or aneurysm. So again, something we're not going to see very frequently, but it unfortunately contributes to a high percentage of maternal deaths that we see. Accounts for about 14% of maternal deaths. This can be genetic, familial, syndromic, or inflammatory. So there's two conditions in particular that we think about when we think about aortic dilation and dangers in pregnancy. One is Marfan syndrome, connective tissue diseases, and a bicuspid aortic valve. And we have certain thresholds where we say aortic size above that threshold becomes more dangerous for dissection. or rupture. And so aortic size less than 40 millimeters for Marfan syndrome is thought to be okay for them to proceed with pregnancy and have a vaginal delivery. If it's less than 45 for a bicuspid aortic valve, same thing, okay for vaginal delivery in those cases. And with these patients, we're doing surveillance very frequently, like every 1 to 2 months, just to make sure that that aortic size is staying stable and we're not seeing any evidence of further dilation. Beta blocker therapy is standard as well for these cases. An acute MI in pregnancy. So mortality is high, again, 8 to 11% in pregnancy. Symptoms would be typical, like chest pain or shortness of breath. But of course, for women, we also think about atypical symptoms, vomiting, reflux, and diaphoresis. Complications are heart failure, shock, arrhythmias, and death. And the workup is going to be the same as we would for a non-pregnant patient. So EKG and troponins, and the treatment, same thing, same for our non-pregnant patients as well. O2, nitrates, aspirin, heparin, beta blocker, and angiography. And then of course, making sure that we're managing the pregnancy as well with fetal monitoring and betamethasone for lung maturity if we think that delivery is imminent. And then lastly, I want to talk a little bit about cardiac arrest. Again, something I hope that nobody here ever witnesses or sees. But I think, again, just because, since we don't see these things commonly, it's important that we talk about them. That way we know what we need to do in those rare cases. So the etiology of this can be varied, can be hemorrhage. So we could have a massive hemorrhage that leads to cardiac arrest, an amniotic fluid embolism, a heart attack, a blood clot, drug use, any of these things and many more can lead to cardiac arrest in pregnancy. In pregnancy, we have an increase in oxygen demand and also an increased risk of aspiration. So really important to protect that airway as early as possible. So early intubation in these cases. And you have compression of the aorta and the IVC in pregnancy because of the weight of the uterus and how big it is. So we want to make sure that that gets placed off to the left to maximize that CPR effort and blood return to the heart and to the rest of the body. And then we need to be prepared for fetal delivery in these cases. So over 20 weeks, so talking about kind of like when do we need to deliver these patients? Under 20 weeks, you just continue with CPR like normal and you continue your normal routine for that. Over 20 weeks, because of all those physiologic changes that I mentioned and how much blood volume is going to the uterus in particular, it can be helpful to remove the pregnancy from that situation to allow for that blood to get back to the heart and be more effective in the CPR. And so the target to delivery is actually 4 to 5 minutes. So when we have very, very sick patients on our floor, again, fortunately, this is incredibly rare. But when we do, we have prepared for us the ability to do a C-section at bedside should we need to. And again, super rare situations, but we want to have that target to delivery within about 4 to 5 minutes. So it should occur at that location of the rest. We use a vertical skin incision to minimize bleeding and maximize our visualization in these cases. And this is just a flow chart demonstrating all of that. So kind of where we go with the code, displace the uterus, do your CPR efforts, shock if it's shockable, and then otherwise you continue on with your epinephrine, et cetera, and then prepare for delivery. So intrapartum management. I have a slide about this pregnancy heart team. So this is really multidisciplinary. So we want to make sure that we have all the teams that may need to be involved with this patient, aware of the patient, and on board with the plan. Whenever we're seeing these patients throughout their pregnancy, we're talking to them about the route of delivery planning. As I already mentioned, an example of where we would recommend a C-section would be somebody with a dilated aorta and Marfan syndrome, for example, because of that risk of dissection. So there are conditions in which we're going to recommend a C-section as the best option. Anesthesia planning, super important with that. So with anesthesia, when they get pain management with an epidural or something like that, That can be really helpful in maintaining their vital sign stability throughout the labor process. So we don't have highs and lows with blood pressures and pulse. That really kind of keeps their vital signs stable. So early epidurals are often recommended. And then they will also plan how they give that epidural in a slow fashion, for example, so that we don't drop their blood pressure too quickly. And then consideration of anticoagulation. If they've been on it already leading into their delivery, when do we need to stop it? When do we need to restart it? Things like that. So this is the pregnancy heart team, and it's based on the WHO classification. So I'm just going to have you focus on this class 3 to 4. So those are the really highest of risk. So you're going to have a huge team involved. Maybe not every single one of these folks, but you're going to have your obstetrician, your maternal fetal medicine specialist, your cardiologist. You might have an intensivist as well on board, your neonatologist, especially when we're planning early deliveries, which we oftentimes will do. So just having a lot of people involved in their care and making sure that we have everybody in the loop about these complicated patients. Immediately postpartum, the highest risk things that we're thinking about are cardiomyopathy, aortic dissection, and acute coronary syndrome. And for the folks that are the highest risk, again, that kind of class 3 to 4, we're really thinking about putting them directly into the ICU, either at the women's hospital or moving them down to Maine or wherever your ICU may be at your facility. Having them on continuous telemetry, doing invasive monitoring in some cases, central line, arterial lines, depending on the scenario, and then strict ins and outs. This is, again, really important, going back to all the fluid shifts and things that happen in pregnancy, making sure that what's going in is also coming out and that we're maintaining a pretty equal balance there. And then after hospitalization, so if you remember, the blood pressure spikes usually about 3 to 6 days postpartum. So we usually want to have an early follow-up after discharge from the hospital. So if I have somebody with a heart abnormality, chronic hypertension, preeclampsia, any of these things that could be related to heart, we're usually going to be seeing them back in the hospital within a few days of their discharge in the clinic to make sure blood pressure is stable, no new symptoms, things like that. Talking about contraception, obviously, we want to make sure that they are staying healthy in that time frame between pregnancies, that they're not getting pregnant too soon after delivery, that we have a chance to reassess their heart function before they get pregnant again. So all of that stuff is really important. And then addressing barriers to care, making sure that they pick up their medications, that they have the money to afford them, that they have transportation to get to their visits. So making sure that we're addressing anything that might hold them up and getting their care. Interestingly, breastfeeding does provide benefit for cardiovascular disease, about a 10% reduction in cardiovascular disease. But I do think it's really important just to mention the caveat here that a lot of our patients who have heart disease might be on a lot of different medications, some of which may not be safe to breastfeed with. So if that's the case, obviously we don't want to end up in a situation where we shame someone for not breastfeeding, but it is something important that if they're able to and want to do that, that can actually be really helpful for them long-term. And then arranging for long-term outpatient follow-up after we release them from our care at about 6 weeks. And that is all that I have. This is a picture of my dog, Callie. We went on a walk the other night, so just thought I'd share that too. So any questions?
I do have a question. In terms of anticoagulation, it's a new initiation. Are you using the NOACs?
We use
Eating risk in that time frame.
We use Lovenox. What would you ask me? What was the
NOAC, like Eliquis?
Oh, no. Yeah. Yep. We don't. There's just not enough evidence for those medications right now in pregnancy. Postpartum, sometimes if they've been on those meds, we will restart them for them postpartum. As far as I know, for breastfeeding, those ones are safe to use. In pregnancy, our standard go-to is going to be Lovenox. Some people, I should mention, some people, and Dr. Peters would probably be able to better answer this one. Some people do require Coumadin. So there is a certain subset population that we do need to use those medications, but we try to avoid that when possible.
Do you see much Marfan's?
We do actually, yes. So, and if you know, remember with your education, and everything, there's different types. There's vascular type Marfan's, and then more connective tissue type, that just have more joint laxity, things like that. But even in those folks that have just the joint laxity symptoms and not the vascular manifestations, they still have about a 10% risk of having aortic dilation. So I still evaluate those folks that have Marfan's, even if it's not the vascular type.
Morning, everybody. Can you hear me okay? So welcome to the symposium. I want to introduce you to Meg Kinney before we start. Meg Kinney is a nurse practitioner that works in our office. She's primary responsibility in our office is managing and diagnosing patients with cardiomyopathies and congestive heart failure. So she, however, today is not my nurse practitioner. Meg is going to be my peripartum cardiomyopathy patient. So peripartum cardiomyopathy, you probably noticed that the title of this talk was postpartum cardiomyopathy. I changed that because by definition, peripartum cardiomyopathy can occur before delivery as well. It's not just a postpartum problem. So the definition of this is a really important thing. This tends to occur in the last month of pregnancy, but it can occur up to 5 months after delivery. So there's really a 6-month window when this diagnosis is made. If it comes earlier than that, it probably is not the right diagnosis. And past that time, you should be looking for other reasons. When we look at cardiomyopathy, peripartum cardiomyopathy almost always results in systolic dysfunction of the heart. And so when you do the echo studies, or whatever way you measure the ejection fraction, it's usually less than 45%. There's rare situations where sometimes it's higher. The most important thing I think in this definition is, though, that you have to make sure there's not any other explanation for this. There's so many other reasons for congestive heart failure that if any of those exist, then that becomes the likely explanation for what's really going on. So you enter in when you see these patients into a pretty big differential diagnosis of things you need to consider. We see a lot of girls during pregnancy get hypertension. I think you might have touched on that with preeclampsia and eclampsia, and I suspect there's some of you in here that had that during your pregnancy. But hypertension occurs with some of these other disorders, but hypertension can also exist as a standalone problem in women from a very young age, and they just happen to come along and get pregnant. And usually what the problem is when they get pregnant, we have to change their medicines because they get medicines that maybe aren't indicated during pregnancy. So then we have to reestablish good blood pressure control. But if they come in with hypertensive emergencies, just like any other adult you may have ever seen whose blood pressure is 250, they get pulmonary edema a lot of times. So this is not the same thing as peripartum cardiomyopathy. We always think about getting blood clots when you're pregnant. Well, if you end up with a pulmonary embolus, that can certainly mimic congestive heart failure when you develop edema and then a sudden onset of shortness of breath. I think amniotic fluid embolus tends to occur most often during the delivery, and that differential becomes very obvious because of what's going on at the time when the patient changes in their condition. But you're doing the same thing with asthmatics that may have had long-standing asthma. Is it an asthma attack? Well, there's such a thing called cardiac asthma. And you wheeze when you have congestive heart failure. And so distinguishing this from bronchospasm is part of the differential. A lot of girls get swelling when they're pregnant. When does that become heart failure? A lot of people get short of breath. I watched the Olympics. The guy running the marathon, crossing the finish line looks pretty short of breath. When is shortness of breath transition from a normal thing to a pathologic problem? And that's part of the, I guess, the art of figuring when the girl comes to the ER and says, I can't breathe, it's probably something more than just a normal. But you have to think about those things. Is this an okay problem for this individual, or is something really wrong? We talked about anemia in the last talk. Anemia develops as a dilutional thing, but then pregnancy also can have hemorrhage, and you can have blood loss anemia. And then there's all the potential cardiac things that can be wrong with the patient that can cause heart failure besides peripartum cardiomyopathy. And I'm going to show you some cases to highlight that. Valvular disease, hypertensive heart disease, ischemic heart disease, and yes, even young girls can get ischemic heart disease because we diagnose type 1 diabetes in people when they're really young. And so you're talking 20 and 30 years of diabetes that I've had patients had bypass surgery, women in their 20s. We talk about arrhythmias. We see a lot of people at the hospital with atrial fibrillation who come in and congestive heart failure due to the rhythm. But then there's hereditary or genetic forms of cardiomyopathy, and they just might happen to show up when they're pregnant. Then there's viral disorders that cause myocarditis, like COVID. How many people with COVID got into trouble with heart failure? Drug use, and not only illicit drugs like cocaine or methamphetamine, but maybe they've had chemotherapy earlier with cardiotoxic drugs in the past. Infiltrative cardiomyopathies tend to be less rare in younger people, like amyloidosis, but we might see hereditary things like hemochromatosis at a younger age, congenital heart disease we touched on in the last talk. And of course, pregnancy, while being a joyous time, is also a stressful time. And if things are going well, then that's good. But we see stress cardiomyopathy in adults. Stress cardiomyopathy can occur during pregnancy as well. So the first case I have is a case that is going to be somebody who didn't have peripartum cardiomyopathy. This is a 25-year-old patient I take care of. It was her first pregnancy. She had sudden onset near the end of her pregnancy of chest pain, comes into the ER. She's short of breath. She gets an EKG there, and she has ST elevation. This was quite a long time ago, so we weren't doing troponins. She had elevated CPK and CKMB. And then she has an echo, and she's got a wall motion abnormality in her anterior wall. And she's 25. She looks like she's having a heart attack. Well, back then, we didn't give everybody primary cath lab intervention. That wasn't the state of the art. We were still doing thrombolytics, and everyone was afraid to give her thrombolytics. So this girl wrote out her heart attack that she was having. She went on to have her baby, and then we decided to cath her after the baby was born. And what we found on her heart cath is what you see an increased risk for during pregnancy is spontaneous coronary artery dissection. And so this girl's LAD was dissected, and they gave her an anterior infarct. Her ejection fraction was low. She would have met the criteria for peripartum cardiomyopathy, but this was an MI. Unfortunately for her, several years later, she developed an apical LV thrombus because of that wall motion abnormality. Went on to have a pretty bad stroke. She's still living with her mother. I still see her every year in clinic. I've taken care of her for a very long time. Another case that I see. This is a patient I also take care of. Wasn't that long ago. This is a 35-year-old. She had severe hypertension and preeclampsia. And because of that, she was taken for C-section. And her post-op course was complicated by a pretty severe hemorrhage. She was at a small town hospital. And with the hemorrhage, she went into shock. So she was pretty sick. And she required intubation. She was moved to a tertiary care center in a larger city. Arrival there, her echo showed her ejection fraction was 45%, meeting criteria for peripartum cardiomyopathy. But she had other things to consider. She had severe blood loss anemia. Could this be stress cardiomyopathy? I mean, it goes on and on. Was this really peripartum cardiomyopathy? Well, they decided it was where she was being treated. Because she was breastfeeding, they didn't use any ACE, ARB, or ARNI therapy. She was placed on carvedilol. She came and started seeing me after she recovered, and she's had a full recovery and has done extremely well. So I'm in my emergency room now, and in comes this lady named Meg. Meg, how far out from your door?
About a month out. And I started to lose weight initially, and now all of a sudden I've gained weight again. My legs look like tree trunks, and my stomach feels like I'm about 4 months pregnant again. Additionally, I can't lay flat to sleep, and I have this cough that is not productive at all, but it is annoying, and it gets worse when I lay down at night.
Have you ever had problems with hypertension?
I had some mildly elevated blood pressures during the pregnancy, but we didn't really get aggressive about treating it.
You're not having any chest pain?
No chest pain.
No.
Mm-mm.
But edema?
Yeah, my legs are huge.
So the symptoms of peripartum cardiomyopathy mimic very much everybody else with congestive heart failure, because it is congestive heart failure. So edema and shortness of breath, again, we come back to, is this normal associated with pregnancy, or normal shortness of breath, or abnormal shortness of breath? And there's always a thing you gotta wonder. She's a month after her pregnancy. She's got her baby with her. And you think you're home free. And all of a sudden, here we are less than 5 months post delivery, and she's got this problem that sounds like congestive heart failure. What I want to show you is a slide here that looks at the incidence of peripartum cardiomyopathy in different places around the world, and pay especially attention to the right side of this slide. This looks by country, but if you notice at the bottom, I mean, at the top, you see Japan, and 6 out of 100,000 patients get peripartum cardiomyopathy. But if you happen to be a woman in Nigeria, you got about a 1% chance of getting peripartum cardiomyopathy. That's a lot. I can tell you in the United States, we don't even come anywhere near that, but we're at like 0.1%. At 103 and 100,000. But you'll go, why is there such a big discrepancy? So it's really well known, and has been for a long time, that people of African descent, people in Haiti, are at particularly high risk for this disorder. So we get into now, what are the risk factors that may predispose somebody to this? And there are a bunch of them. Pretty high on that list is being of African descent. But if as you get older as a female, your risk gets higher in older women that get pregnant. If you have more than one baby in utero, so twins, triplets, etc. If you have had or do have pre-eclampsia or eclampsia, you are at higher risk. If you've had hypertension associated with pregnancy, you're at higher risk. If you used cocaine, if you've had more than 3 prior babies. It turns out this disorder is not that common. So most girls that get pregnant are having their first or second, and there's not as many having their fourth and fifth. So most of the cases still occur in the first and second pregnancy just because of how prevalent the disease is. But the more kids you've had, the higher your risk is going to be. And then tocolytic therapy is when you suppress delivery or the end of the pregnancy, and I think they use mostly terbutaline. But if you're on tocolytic therapy for 4 weeks or longer, it raises your risk. So here's another case of a not peripartum cardiomyopathy. Another girl I take care of, but it was a girl who had heart disease during her pregnancy. She's 35. She's from the Marshall Islands. Some of you may have actually had the pleasure of taking care of this girl. Her dream in life was to come to the United States. She came and she gets here and she ends up in the hospital with congestive heart failure. So she's short of breath, is about a month of being short of breath. And she's found that they thought she had pneumonia. So they treat her for that. She doesn't get any better. Ends up coming in to the ER when she started having the same symptoms Meg is having. She can't lay down. She's short of breath every time she lays down. When she came to the ER, her blood pressure was 215 over 126. We did an echo on her. She was in heart failure, and that is not her heart on that slide, by the way, but this is what her heart looks like. She had severe left ventricular hypertrophy. Her heart function still looked pretty normal, but she had torn mitral valve chordae and severe mitral regurgitation. We treated her with your typical guideline-directed medical therapy. I mean, she's not telling anyone what her pregnancy plans are, and my fault. We didn't ask her. We put her on all the right drugs, and she shows up a month later in the office and she's pregnant. So now we gotta like back off all these different drugs. But now we have to manage this girl with congestive heart failure and valvular heart disease and severe hypertension during a pregnancy. So we get her through her whole pregnancy. She decides when she delivers, she's going to breastfeed. So that continues to restrict a little bit the typical medicines we use. She's seen the surgeon and they need to fix her mitral valve. That's what she actually needed. And she comes in to have her surgery, and she's done breastfeeding, and she's in pre-op, and the surgeons order a pregnancy test. And much to her surprise, she didn't know it. She's pregnant again. So she had to go through a second pregnancy with this problem. She did well. The second pregnancy, she decided not to breastfeed. Before she could get pregnant, she came in and had her valve fixed, and she's actually done really, really well. So symptoms. We talked about symptoms of congestive heart failure being edema, shortness of breath, orthopnea, right? Short of breath when you lay down, PND, you wake up, you're short of breath, have to get up for a little bit to get your breath back. Sometimes associated with arrhythmias, you may have syncope, feel heart palpitations that are associated with cardiomyopathy. But then we come to the physical exam of these patients, which is part of what you need to confirm the right diagnosis. What's your physical like, Meg?
So my physical exam does show 2 to 3 plus pitting, lower extremity edema. I've had noticed some neck veins in the mirror, and Dr. Peters saw those as well. When he listened to my heart, it sounded kind of like a horse. And then my lungs, there's like some funny noises in the bottom part that we call rails. And I do have a little bit of a murmur as well on exam.
So many women, when they're pregnant, have flow murmurs. We're a month postpartum, right? So the heart sounding like a horse, if for those of you who aren't familiar with that, is the gallop rhythm. And but again, I don't know. You always got to wonder, because what phase you're in. Are we a week before delivery and there's swollen legs? Do they have this big baby in their abdomen still and they don't feel like they can take a deep breath and they complain of shortness of breath? All those things you got to keep thinking about, because what phase are we at, pre or postpartum? Heart failure is often described as people as feeling like they're drowning. That's why I put this slide in here. It's like you can't get you just feel like you can't breathe no matter what you do. So once you think that this may be what's wrong, you have to start doing diagnostic testing to try to confirm your suspicions. And the simplest things are going to be x-rays. Echo is very safe to use. We use ultrasound on pregnant women. We can use ultrasound on their hearts too. So we do echoes, and echo is an invaluable tool because, again, we need to see LV dysfunction. And if it's not there, they don't have this diagnosis, and you need to keep looking for some other explanation. The EKG might tell you if they're ischemic. The EKG might tell you if they're out of rhythm. The patient don't always feel their heart rhythm. ProBNP is another test that's become really used to distinguish heart failure from other entities. Elevation of the ProBNP or the BNP can be pathognomonic that this is heart failure. Now you got to figure out what's causing the heart failure. But if the ProBNP is normal, it virtually excludes that diagnosis. There is a gray zone where it's elevated, but you're not sure if it's high enough to be heart failure yet. So, but it's a helpful test. When I say tests of exclusion, we went over that differential. You got this long list of stuff that you got to make sure it isn't there, like a pulmonary embolus. So you may need a CAT scan of the patient to tell if they got a pulmonary embolus. You're going to do other tests to make sure there's no other condition. This is a pretty simple case report, but I'll come back to it later. But this is another girl that I took care of. She's 25 and she came in, and the day after she delivered, she got short of breath. She was diagnosed with peripartum cardiomyopathy. Her ejection fraction was 35%. She was put on standard therapy with, I'm pretty sure she was on enalapril and carvedilol at the time. She got better very fast and had full recovery of her heart function. And that comes into the treatment. So what do you do about it? And you got to remember, this is what makes this different than the other patients we take care of in our normal daily lives. Is these girls are either pregnant or just had a baby. So you're thinking, what can I give them safely that's not going to harm their baby? Because I know what they need and what they can take is two different things sometimes. I also got to think that Meg's probably going to tell me she wants to breastfeed. I got to make sure the drugs that I pick are safe when they're going to be doing that. And then at the end, can they get pregnant again? Is it safe? So those are a lot of the treatment decisions you have to consider when you're making choices for these people. So are you going to breastfeed?
I would like to try to breastfeed for a couple months at least. I think it'll be hard when I go back to work to continue to breastfeed. So let's start with breastfeeding, and then we can try.
I'm going to go through some slides for you guys that kind of talk about the drug therapy for peripartum cardiomyopathy. So we have 3 beta blockers used for treating cardiomyopathy. There's metoprolol, carvedilol, and bisoprolol. All the other beta blockers have not been shown to be beneficial. Only these 3. So that's why if you take care of these patients, you're always seeing them on usually metoprolol or carvedilol. In a head-to-head trial, carvedilol was better than any, but we don't use it as first-line therapy, even though we've seen it being used in some of these case reports. Metoprolol is preferred because there's a lot of information about its safety. It's safe during pregnancy and it's safe after delivery and breastfeeding mothers. There's not much data on the others, and so it's not recommended to use them generally. These drugs, however, are powerful in cardiomyopathy management. They make the left ventricle better. They reduce the arrhythmias that come with LV dysfunction. They improve the survival of the patient, and they also can be used to treat their hypertension. Another major category is standard of care. These are the class 1 indicated drugs, ACE, ARB, ARNI. Well, there's not a lot of data again on the ARB class. That's recommended to use that, and very cautiously if you do, only in breastfeeding and not during pregnancy. And the ARNI is a heart failure drug that has an ARB in it, plus an additional agent called sacubitril. This is otherwise known as Entresto. It's the only drug on the market in this class. So I'll give you the brand name for those that aren't familiar with it. No data on it, on sacubitril, and the ARB has already got caution, so we don't tend to use that. We use enalapril. Enalapril, however, is only after delivery and not during pregnancy. So if the mother has this problem develop at end of her pregnancy while still pregnant, you can't start it yet. MRA, mineralocorticoid receptor antagonists like spironolactone and eplerenone. No data on eplerenone, so the only one used is spironolactone, not used during the pregnancy, limited to use post-delivery. Our time's getting short, so I'm going to start going quicker. If the person is really sick, then you start to look at other things that you do, because you got to try to keep the mother alive. They may not be just popping out of this because you gave them a dose of Lasix. Norepinephrine is the preferred inotropic agent. It's preferred over all the other ones. Milrinone, we tend to use in right heart failure. Dopamine is considered okay, but they recommend avoiding dobutamine. There's a lot of other drugs used in heart failure. Combination of nitrates with hydralazine. Turns out those have been around so long, they're okay to use during and post pregnancy. Bromocriptine, I'll talk about again in a little bit, but it's some studies being done looking at bromocriptine in these patients. Digoxin is known to be safe. Loop diuretics, furosemide is the preferred diuretic there. Anticoagulation, somebody asked about earlier. During pregnancy, low molecular weight heparin is probably the preferred agent, and afterwards, actually warfarin is preferred with low molecular weight heparin over the NOACs. The NOACs don't have enough data to say they're safe, and getting that kind of data is a challenge when you know you have other safe agents to use. So it may not ever be known how safe those would be. As they get sicker, now we're talking about the stuff we use on everyone else: balloon pumps, ECMO, LVADs, even a heart transplant. These patients can get that sick. Device therapies for persistent LV dysfunction still includes, in these young mothers, defibrillators, and if they have conduction defects like left bundles, cardiac resynchronization therapy type pacemaker. But always remember, you got two patients here. You got the mother who's either got the baby in her or the mother who's probably breastfeeding her baby. So you have to always remember that when you make choices and decisions with this. Another case I saw, this was in the news, NBC reported this, a lady named Elizabeth Chuck. This has actually happened at Christmas time this year. 23-year-old girl went in, had twins, went home and celebrating her new family, but started not to feel right after she got home. She vomited, fainted, has a seizure, and I think she had preeclampsia. So they thought, is she eclamptic? She goes back to the hospital, but instead she was in pulmonary edema and was diagnosed with a peripartum cardiomyopathy. She did not respond well to treatment. She rapidly went downhill. You can see the date of her delivery, December 19th. And this lady was dead on December 28th, 9 days after her baby was born from overwhelming heart failure. Died of a cardiac arrest. Just remember, this is not a minor disease. This is one of those where people can get really sick. How long do you treat patients? You know, they didn't know this back. I told you about that lady that had a pretty straightforward and got completely better. They didn't know how long this disease required treatment. And this patient of mine decided to do her own research because she kept asking me, I'm only 27, how long do I have to stay on this? And I said, well, however long you live. So she decided to go find out on her own. And there was no studies, there was no data. She found doctors that took care of people in Haiti and in Africa. And it turns out what she learned is that in those countries, everyone got to start treatment, but nobody could afford to stay on treatment because they're poor. And so what they found in their stuff is that if you went on medication, if your heart completely got better and you just went off treatment, you did fine and stayed better. But if your heart only got partially better and you stopped treatment, your heart would get bad again. So they told her it would be safe for me to withdraw her therapy, and I did that over about a 2-year period in a stepwise manner. And she's done so well. I never stopped seeing her. She's normal. So we're close to the 5-minute warning. Meg.
So now my baby's 2 years old, and my husband and I are really talking about having another baby. We talked about maybe going off meds. What is the chances that this is going to happen again? And how are we going to proceed if I do get pregnant?
Answer to that question just depends on your heart function. What they now know is that you have a full recovery of your cardiomyopathy from the prior event that you had. If you get pregnant again, there's a pretty good chance you're going to get your cardiomyopathy again, but they tend to do well and recover completely again. But if you don't, you're like that one that wants to get off medicine. Your heart's not completely better. When you get pregnant again, it will really likely come back, and it may never get better. And you might be like the girl that we just saw in Utah who didn't survive. So a very risky thing to do in people who don't have full recovery. And we usually recommend to them that they not have any further children and to find ways to make sure that happens either through tubal ligation, long-term birth control, their husband gets a vasectomy, whatever method they use to ensure no further pregnancies. This slide is kind of the last one I have, and I just want to tell you what's been going on and try to figure out why this disease is different. There's certain things that they have sorted out. Most of this happens in the lab, but there's those, the second, third, and fourth are like steps. But the 16 kilodalton prolactin fragment that's made tends to be abnormal in these patients. And it ends up causing this step that causes endothelial damage. And they think that's actually the mechanism behind this now. Well, the 16 kilodalton prolactin fragment can be inhibited with bromocriptine. I mentioned that earlier, that it's still controversial. In mice, when they give this to mice, they know in pregnant mice they can prevent peripartum cardiomyopathy. But now the next step is, what does it work to treat it after it's developed? And then you got to expand that to the human. The problem with bromocriptine is it inhibits lactation. So now you make if you give it to every girl so they don't get this, then nobody can breastfeed probably. So bromocriptine, what it means to me is they're starting to understand the steps in this process. And if they are starting to do that, they may find other therapies that can intercede to stop and maybe treat this. But they're a long ways yet. There's a lot of research to be done there. And that's really all I have. I would entertain any questions. Crystal, right?
No.
Yes.
One question.
Yeah.
Do cardiac MRIs on these patients if you're looking at some type of myocarditis?
I guess the answer, I wouldn't be afraid to do the MRI. It would be whether you give them gadolinium. I don't know. Is that safe?
We don't get gadolinium.
I would worry about the imaging agent. But without that, I'm not worried about the magnet. But I haven't seen that it's going to help in the diagnosis. Now, I'll tell you, one of the things in this last slide, they talk about, they do biopsies on some of these women and they don't have cardiomyopathy, they have myocarditis. Again, maybe they're misdiagnosed as peripartum cardiomyopathy. They have a different problem. They also noticed there's a lot of gene stuff being done in cardiomyopathy, and there's a whole bunch of genes associated with hereditary forms of cardiomyopathy. The panel is huge when we do it on as a screening thing, but 8 of those genes overlap with peripartum cardiomyopathy patients. When they do these genetic tests on them, they have it. So the question that comes up in that is, are these kind of like women get hypertension when they're pregnant, gestational hypertension? Turns out they go on later in life probably to get hypertension. You get gestational diabetes, you didn't have diabetes, but you got it while you were pregnant. Years later, you probably are going to be diabetic. Well, it turns out some of these people have a gene for cardiomyopathy. And are we really seeing their dilated cardiomyopathy show up when they're pregnant? It settles down, and then maybe 30 or 40 years later, they got their cardiomyopathy they were going to get to begin with anyway. It's just the pregnancy brings that out. They don't know the answer to that, but it's just kind of, to me, food for thought that this is maybe a complex set of disorders, not one thing. Anybody else? Have a good break.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.